and I work at Queen Mary University of London, and I'm a GP. And the problem that we were trying to deal with is related to kidney care. And the first problem is that the accrual rates of end-stage renal failure in East London are higher than those for England as a whole. So that's one bit of it. The second part of the problem is that GPs and practices are not that good at managing chronic kidney disease.
When a patient's referred to nephrology at the moment, I'll get a letter that includes very little of the information I actually need and a great deal of information that I don't particularly want. The patient will be booked in to see me in around 3 months' time. She'll usually come up from a distant borough with none of the information from the many hospital appointments that have happened in the interim, and often by transport. When I see her, I'll examine her, briefly chat to her, and then duplicate every investigation I can possibly think of. I'll book an outpatient ultrasound, and she'll return to my clinic after around 2 or 3 months have elapsed, at which point it will become apparent to me that there's not a great deal wrong that I couldn't have dealt with by giving advice, and that I'm not going to change a single thing.
A lot of planning went into developing the e-clinic, which was a very complex thing to do, and it took us a year to sort out EMIS Web being available that way. It took us about 6 months to develop the dashboards and to encourage all CCGs to use them.
The enhanced facilitation, what we did was we chose the practices that had the lowest rates of coding. I went to the practice and met with practice nurses, with practice managers, with the GPs of course, and I went with the aim of talking to them about the resources that were within the East London Community Kidney Service.
So we also developed something called trigger tools, and we brand these as safety tools for practices to use. And what they are is each practice runs a search, and it reports back on cases where there's been a value of eGFR less than 60 and where the previous result is 10 mils greater than that. So what we're looking for is cases where there's a falling eGFR.
It was about half a year ago when one of my GP partners went on maternity, was about to go on maternity leave, asked me to take over the role, right, as a trigger tool lead, so to speak, at our practice, and I've been doing this for a year. Is the fact that each and every clinician gets involved in patient care. I think that's a great benefit. Rather than having a clinician looking after all patients themselves, even if they are not their regular GP. So I think that's a great benefit because you end up talking about it in the clinical meetings, and I think it stirred up, created great awareness, I think, amongst us.
So this service is now into its 5th year, providing care for 1.2 million people across 4 boroughs. We offer easy access to expert nephrology advice and rapid appointments for those most in need in a face-to-face environment. We have a suite of tools that enables good coding of CKD and good management of CKD in the community, as well as a monthly trigger alert system able to find those most at risk of progressive chronic kidney disease. We also have an education offer built around individual and group education for patients that enables best self-management.